Okay.
Good evening, everyone. My name is Beverly Cunningham, and I am the lead for Aberdeen Street Health Foundation. And I greet everyone that has logged on to tonight's Friday Focus Seminar in the mighty name of Jesus. The Friday Focus Seminar this evening is focused on COVID-19 and the impact on BAME communities. Firstly, I would just like to go through a few of the seminar etiquette guidelines, as was just shown on the welcome slides for those that have come in afterwards and didn't see those. So we'd like that your device is named, so we can see an actual name and not the name of a device or a phone. Can you please keep your audio on mute unless you are invited to speak? Please use the chat facility to forward any questions during the seminar. And just finally, the seminar is being recorded live and is being streamed on YouTube. So before we go any further, we would like that we ask the Lord's blessing on this evening's proceedings. So I'd like to hand over now to Sister Doreen Oliver, who is going to open up in prayer. Sister Doreen, thank you. Sister Doreen?
Heavenly Father, we thank you for your grace towards us. We thank you, Lord, for the opportunity to come here today in this way, to gather together. And we thank you also for our guest speakers and for the time that they've given to come with us. We thank you for our friends and we thank you for our church members. Lord, we thank you for the day. And I pray, Lord, that as we have our discussion, that you will be with us, that you may help us, Lord, and that ultimately all of this will be to the glory and to the honor of your name. Lord, we look to you, God, and we are grateful and say thank you once again in Jesus' name. Amen.
Amen.
Over to you, Bev.
Amen. Amen. Thank you, Sister Doreen, for that prayer. Thank you. So, good evening, everyone, again. If you weren't able to log in last week was the first Friday Focus Seminar of a series of 6 Friday Focus Seminars. Last week, we looked at nutrition and my immunity. Does it matter? And that was presented for us last week, a really fantastic presentation by Yvette Besley, a naturopathic nutritionist who imparted invaluable information to help us strengthen our own personal army, our immunity, to help us fight at this time that we find ourselves in with this invisible enemy. So if you weren't able to join in last week, then I would encourage you to go to the Aberdeen Street Church of God of Prophecy YouTube channel and just to have a look at that presentation from last week. You will find a lot of beneficial information. Tonight, we are joined by Dr. Justin Varney, Director of Public Health, and Councillor Paulette Hamilton from Birmingham City Council. And, you know, I'll just reiterate what Doreen prayed as well. Thank you very much, both of you, for giving up your time on a bank holiday evening to come and engage with us as a community. So thank you very much for that. And tonight we're looking at a hot topic, COVID-19 and the BAME community. But just very briefly, for those that might be wondering, ASH Foundation, Aberdeen Street Health Foundation, who are you? So we are a voluntary group of Christians. We attend Aberdeen Street Church of God of Prophecy in Winson Green. We were formed in 2017 with a primary focus to support the church congregation and the local community in terms of maintaining good health. We're a group of individuals that work in the NHS, health and social care, or in education. And, you know, we just came together to try and give back something to the community and the church congregation. So for this series of health promotion information, we have collaborated with Birmingham City Council, and also Yvette Besley from My Nutrition, and also Birmingham Community Healthcare NHS Foundation Trust. And we really wanted to do something at a local level at this time of coronavirus, and, you know, to try and look at practical things, self-help practices, evidence-based information that we could impart to the community for people, individuals, to self-help at this time, and also for the faith community as well, to engage and interact with the NHS, with local government as well, and for them to interact with us. So that's what we're hoping to get from these seminars, really, is that collaboration, that connection, that networking with local government and the NHS to be of some benefit to the BAME community and wider communities as well. And we're hoping that, you know, this model could be replicated in other faith communities also. So we want to be mission intentional about this, and tonight we're going to engage in a series of question and answers. But before we get into the nitty-gritty of the questions and the answers and the discussion, I'm going to hand now to Dr. Justin Varney, who's going to start us off, and he's going to look at COVID in a nutshell to start off with, and then he'll pass to Councillor Hamilton, and then after Councillor Hamilton has spoken, then we will get to the questions that have been sent prior to the seminar starting. And as I said earlier, you can also pose questions tonight on the chat facility. So without further ado, I am going to hand over to Dr. Justin Varney. Over to you, Dr. Varney.
Thank you, Bev. So what I'm going to try and do today is just give you a bit of a summary about coronavirus. What is it? Where did it come from? And the journey that we've been on in Birmingham with you over the last couple of months as it's joined us in the city, unfortunately. So coronavirus is a family of viruses. The one that's specifically causing this outbreak is called COVID-19. And the coronavirus family, the best way of kind of thinking about this is it's a bit like calling something a tomato. You know, it's a family of things, but there are different types of tomato. And in the same way, there are different types of coronavirus, and they all behave slightly differently. So within the coronavirus family is the virus that causes the common cold. There's also the virus that caused SARS a couple of years ago, and also the MERS outbreak as well. So COVID-19 is a new strain of the coronavirus family. It originated back in December in China. That's when China found it in the Wuhan region and alerted the World Health Organization. And then we saw the virus spread across the world, first into Iran and Italy, and then started to appear across the rest of Europe. And we had the first cases in the UK back in early February. And then towards the end of February, we saw transmission within the UK between people in the UK. And we had the first cases in Birmingham about the second week of March. And the case numbers, unfortunately, have risen quite rapidly since then. So it's been a relatively short period of time. And if you think, you know, we're only just in May now, and this first came into Birmingham in March, it's not that long ago. Coronavirus spreads. Initially, we thought only when you had symptoms. We now know that there's some spreading from people who haven't got symptoms, but it's spread through having close contact, so being within 2 meters of someone else, and that's because it's spread through the little droplets that come out of our mouth when we cough or sneeze, or when we're breathing very hard, when we're exercising, for example. those little things that spray out of our mouths, and they either land on someone else directly, or they land on a surface, and then we touch that surface, and like any other germs, they stick to our hands, and then we touch our face, and the virus basically crawls across our face, into our mouth, up our nose, or into our eyes. And this is the part of your body that is vulnerable. The virus can't burrow through your skin. It only can get through the wet bits, in effect, on your face. And that's why it's so important that we ask people not to touch their face and to wash their hands. Good old-fashioned soap and water kills the virus. You don't need any particularly fancy products. It is hot water and soap. And so washing your hands regularly, not touching your face, and keeping those 2 meters distance are the most effective ways of stopping the spread of the virus. So we've seen this increase, and it feels like many weeks ago, the government put us into lockdown, asked us to stay home, to work remotely where we can, and to really limit interaction between people and keeping those 2 meters distance. And that has been very effective in slowing the spread of the virus. In Birmingham, we started off with a slope in terms of new cases that was going up like this. And because of lockdown, it started to do this. And we can really see the impact that we've had in Birmingham in terms of everyone doing what was asked, staying home, staying safe. And that has undoubtedly saved lives and really has reduced the spread of the virus. More recently, we've been able to get better analysis of the data, and that is suggesting that there is a difference in terms of the proportion of people who die in different ethnic groups. And that's suggesting that particularly in African and Caribbean communities and in Bangladeshi communities, that even when you take into account some of the other factors that impact on the proportion of people who die, like age and gender, for example. So we know that more elderly people are much more likely to die, and men seem to be more likely than women to die. But also these ethnic groups also have a higher risk. Some of that we can explain because of the distribution of diseases like type 2 diabetes, of high blood pressure, of kidney disease. And if you have those conditions, you're likely to have a worse outcome. But if you also have those conditions and they're not very well looked after, they're not very well managed, then your outcomes are likely to be worse. And all the research we've had over decades has shown us that there are inequalities affecting different ethnic communities in terms of those diseases and how well they're managed. And that's a bit about how we look after ourselves, and it's a bit about how the NHS looks after us as well. So it's those things together that's creating the gap. And in effect, how you came into this in terms of your own health, it has a big impact on how you respond to COVID if you catch it, and your chances of death. But it doesn't all seem to be explained by that, and that's why there's a new national review to try and crunch the national numbers and understand them a bit better and see, is there something else we're missing? Is there something else we should be doing? But in the meantime, the key message for all of us is stay home as much as possible, wash our hands more frequently, don't touch our face. And if you have got a cold, if you have got a temperature, if you have got symptoms, then please stay at home and isolate. But if you get sick, ring the NHS. And that's probably the final point I just want to make in terms of the nutshell of what we're seeing at the moment, is not only have we seen an increase in the number of coronavirus related deaths, we've also seen an increase over April in deaths that didn't have coronavirus on the death certificate. And that makes me deeply concerned that there are people who have been sitting at home with crushing chest pain or acute shortness of breath or stabbing abdominal pain and haven't rung an ambulance or haven't spoken to their GP because they're scared that they'll catch coronavirus going into hospital. The NHS has worked incredibly hard to make sure that if you are sick with something that's not coronavirus, we know how to keep you safe and to look after you going in to try and protect you. And there is a real concern that during this period, some people may have died at home because they were too scared to reach out for help. So I think there are lots of things going on in this space. There's a lot of work still to come. And we are really keen to do what we can. It's fair to say the council has really limited access to some of this data. Most of it sits within the NHS. But the important thing actually is to talk to communities in events like this evening and have the conversation, so we can answer the questions as honestly as we can and be open with you about what we know and what we don't. There's still far too much we don't know, but in the meantime, we'll give you the best advice that we can based on the current situation.
Thank you, Dr. Varney, for starting us off there and giving us that bit of background, so we're all at the same starting point. Thank you for that. Obviously, like I've said, we've got a lot of questions to pose during this evening, but we do know, I believe on the 23rd of April, I think it was the 23rd, there was an emergency health and wellbeing meeting that was chaired by Councillor Hamilton regarding the impact of coronavirus in the BAME community. And that meeting was held with some very senior individuals. Councillor Hamilton, would you be able to feedback on that meeting for us? Let us know what happened, what the outcome was, where you are now, and the hopes for the future following that meeting. Is that okay, Councillor Hamilton?
Yeah, let me start by saying good evening to everybody, and just start by saying this meeting didn't just happen. What happened in Birmingham was we started to see a real increase in deaths among Afro-Caribbean and the Asian community, and people became very nervous, to the extent where those people that are on social media, WhatsApp, people started to say, we are not going to go to hospital because they're putting us into COVID wards and they're trying to kill us. That's how far it went. So what I then did, with that and a number of cases that I knew about personally, I called all the health chiefs together. So the chief executive of UHBT, the chief executive of Sandwell and West Birmingham, all the medical leads, and Justin, the public health director. So we had a meeting. And at that meeting, I really highlighted the fears that were in the community and the fact that as the Health and Wellbeing Board chair, something needed to be done, and it needed to be done quickly. And people needed to understand what this condition was, what this virus was, because there was just fear with very little understanding of both the condition and what it could do. So we then decided to have a Health and Wellbeing Board the following Thursday. It happened within 5-6 days of the meeting. But before that, I needed to ensure that local residents had their say. So I embarked on that publicity trail where I went out into social media, went on radio, spoke to people who I knew well, and I said, I need your questions. This won't work unless the people at the top of organizations understood how the communities were feeling. That wasn't just the African and Caribbean community, but also our Bangladeshi, our Pakistani, our Sikh community. We needed to know what communities were feeling. So we had the Health and Wellbeing Board, and we had over 600 questions. Some of them, we had 209 people, I think, sending questions, but each person had 2-3 questions. So it added up to over 600 questions. So on the day, we embarked on, we grouped the questions into different groupings, and we embarked on asking the questions just to ensure that people started to have an understanding of what we were dealing with, because this is a pandemic, this is serious, this kills, and a lot of our people did not understand this and they were getting frightened. So we had the meeting, and the aim of the meeting was, once the meeting was held, Matt Hancock had recognized probably a week before, while we were doing all of this, that he needed to have an inquiry about the large level of deaths in the health service among the BAME community. So he was absolutely clear this is what he wanted. So what we then did, we said we would do this and we would kick the inquiry off. So we would ensure, we wrote to Matt Hancock, we sent him a link to the meeting on the day, we would send him the 600 questions, we would also ask him to get Birmingham submissions. This is what we did. And that culminated in last Monday, us being invited to the first stakeholder meeting that was being held by Public Health England, who were then given the task to head this, well, I thought, inquiry up. When I went to the meeting, as everybody knows, it was changed from an inquiry to a review, and it was really only data driven and nothing else. And I really wasn't very happy about it. But at this moment in time, a review is underway, and the review will report back to the government by the end of May. And I'll leave it there. Thank you.
Can I just ask on the back of that, Councillor Hamilton?
Yeah.
You're hoping for an inquiry?
Yes, I am.
Inquiry.
Yeah.
But that's been stepped down to a review.
A review, yeah.
So just for clarity for us, what's the difference between inquiry?
Yeah, I hear you.
Review?
Well, what they've done is they have put it over to Public Health England, and they've stepped it down from a proper full inquiry where they can look at what people were feeling at the time, look at the death, the issues within the community at the time. They could look at the inequalities in health. They could do the whole remit, and they've just stepped it down to looking at the data at a specific time, and it's just a review. So they narrowed the remits of the review, and what that means is we won't get a qualitative review that gives us a full outcome and things we can then act upon.
Okay, that sounds to me quite disappointing, actually.
Well, I was devastated. As Justin will tell you, I was devastated. He had to well, he'll tell you himself.
Talk you down a little.
Okay, I was just going to say, I don't know if Dr. Varney wants to come in on that, because in terms of just looking at data, that's assuming that, in my understanding, is that all the different secondary care, the acute hospitals, are collecting equal amounts of data. And what about the data that wasn't collected initially from the care homes and the BAME community that might be in care homes? So is it going to be reliable data that they're viewing and commenting on? Is it going to be, how reliable is it going to be?
Yeah, so it's really important. There are a couple of things to understand about the data and why this is, partially why this has taken so long to see and understand. So back in April, there was an initial report looking at a few hundred cases of people in critical care across the country that looked and said there is some ethnic difference in people in intensive care and in deaths. However, it only looked at ethnicity alone. It didn't try and take any account for age or health condition or anything else. And there was a much stronger difference for age. So that was kind of, at that stage also, because it was such small numbers, so in the study you may only have had, say, 10 Irish people. When you put what's called a confidence interval, so it's a statistical thing where you say how wide is the band in which we think the real answer lies, it's very big, it's off the screen big. So you need a lot more numbers, and in the second report there were a lot more numbers, and that started to say, actually, we think there is definitely something here that's worth investigating. So then we've seen more work done by the NHS based on hospital data. Now, in hospital data, as you all know, when you go in and when you register with your GP, they ask you your ethnicity, they ask all sorts of questions. And they have been required to do that for some time. However, there's still significant gaps. So I think we're only up to about 90% coverage for ethnicity in some hospitals. It's even lower. So that's how they were able to do some of the analysis. However, in death certificates, ethnicity is not recorded, nor is faith. And at the moment, most of the information we have on what's happening in care homes is coming from the death certificates, not from the NHS data. Now, I think what the National Review will try and do is do major number crunching to look at the address that people have, to match that with information from the Care Quality Commission. So they'll try and do some what's called data matching to try and join the dots. But at the moment, the only really data set that has ethnicity in it is hospital data, because GP data is held separately. And therefore, most of what we know is based on the people that are sickest in hospital. And that, of course, does mean that there's a bit of kind of skewing of that data, and a lot more work's needed to actually really understand it. But it is patchy. You know, and particularly when we look at some ethnic groups, recording's really low because people still don't feel safe giving that information to the government, and that's one of the real challenges in this.
Thank you for that. Okay, so we want to get into the questions because, you know, we've asked people to send questions in, so we do want to get into those questions. As Councillor Hamilton has said, there has been a lot of sharing of information on social media. Some of it may be factual, some of it may not be factual. I don't know, we don't know. So it would be good as we're going through the questions as well to try and dispel any possible myths that have been circulated. So I'm going to start with some of the questions that have been sent in, and we thank everyone that has sent questions in, and we will try and get through all of the questions if we can in the time that we've got. The first question was sent in from Georgia Blackwood. So, in light of the publication of quadruple rates of BAME deaths in comparison to the white population due to COVID-19 and have been identified as a vulnerable group, how are we to be protected at work? I'm specifically interested in provision for lower grade workers. I don't know, Dr. Varney.
Should I pick that up? Yeah. So first of all, just to be really clear, actually what the researchers found is it's not quadruple the rate. That if you read the research reports that I think Georgia's quoting from, once you take into account people's age and their gender and their deprivation, actually it comes down. So I mean, it's still high. So men and women from Black ethnic backgrounds had a death rate of almost double, about 1.9 times higher than white people. And men from Bangladeshi and Pakistani backgrounds were 1.8 times more likely to die than white men, while women from the same Bangladeshi and Pakistani backgrounds were 1.6 more likely to die. And although some of the other ethnic groups were more likely to die, those are the kind of two big groups that were significantly higher. And that analysis, which is one of the largest bits of analysis that's been done, still didn't really get to an answer about what's going on. I mean, it gradually honed down in some of it, and particularly around things like high blood pressure and diabetes as well. And I think the key message in terms of what does this mean for work, you know, the vulnerable list, so there are two lists. There's the shielded list, which are the people that are extremely vulnerable. They're people who've had things like organ transplants or are on immunosuppressant drugs that that block their immune system, in effect. They're the ones that are shielding for 12 weeks. And then there's a second list, which are the vulnerable list, and that includes the over 70s, but the people that in a normal year would have the seasonal flu jab through the NHS. And that includes diabetes, high blood pressure, also includes pregnant women. And what the research is showing so far is that in these ethnic groups that have higher death rates, those conditions are higher as well. And what we need to understand better is it also that those people who have those conditions, they're not as well managed. And that comes back to the point I was making earlier, that some of this is not whether you have diabetes or not, it's how well your diabetes has been looked after that may put you at higher risk. But the key thing is, does it make any difference? Well, if you're in a vulnerable group because you've got one of those conditions, you should already be having a conversation with your employer if you're in a frontline role, because you should have already been having that conversation, and then a risk assessment that's specific for you is undertaken. And I know that across the NHS care system, for example, very, very few pregnant women are still working in the front line. The other thing is that if you are working in the front line, you should have the personal protective equipment that's appropriate to the thing that you're doing. So if you're doing an interview with someone, for example, you might be a social worker, you can do that sitting 2 meters apart, in which case you don't need the full spaceman suit protection. If, however, you're intubating someone, you're putting a tube into someone's throat to help them breathe, and you're helping to assist with that because you might be a nurse working with a doctor, that is what's called an aerosol generating procedure. In that case, you need a special type of mask, you need a visor or glove or goggles, you need an apron and gloves. So the protective equipment is specific to what you're doing, not to who you are. Whether you should be on the front line or not depends on your health situation, and that's where you should be having a conversation with your employer. And if your employer has occupational health, you should be talking to them about it.
Okay, thank you. Thank you. Technician, can you go? Thank you very much. Okay, so thank you for that. Second question, just slightly lower for me, Mark. No, top of page 1, Mark. Mark, can you go back to the top, please? Stop, thank you, thank you. Okay, thank you. Okay, I will try and pose this as best as I can. Are ethnic minority groups affected worse by the virus in comparison to their white counterparts? That has been established. If so, shouldn't it be a cause for concern as there's a higher volume of ethnic minority workers contributing to the NHS? Isn't this a slight oversight by the government and a potential health and safety risk towards white NHS staff?
So I'm not quite sure I understand the question clearly, Bev, but I think what the Georgia's trying to get at is...
This is not Georgia, this is a second question.
This is someone else.
Yeah, someone else.
Yeah, so I think we do know that there are many more ethnic minority people working in the NHS than in other industries. And many of the deaths in the NHS have been in ethnic minority people. However, they've been doctors, they've been nurses, they've been healthcare assistants and porters. They've been every different grade, working in lots of very different situations. And the NHS is doing a very specific piece of work to try and understand what's going on. Is that because they didn't have the right protective equipment? In the early days, the first couple of weeks of this, we didn't think you could spread the virus if you didn't have symptoms. So we had different guidelines. They've been updated as more evidence came, particularly out of Italy and of Spain, that we understood more about how this virus spread. And of course, some of the people who died would have caught it back in those first couple of weeks, but we need much deeper analysis to understand that. I mean, ultimately, a bit like the first question, the key thing here is if you know you've got a health condition like diabetes or high blood pressure, you really need to talk to your employer about it so they can make sure a risk assessment's done for you. This is not as much about your ethnicity, it's about your health status, and that's very personal, so everyone's going to be slightly different.
Okay.
Bev, I just wanted to add, as many people have been medical people that are on this call, you know that when we were all nurses, the one thing people used to say, if you divulged your medical condition, if you had mental health issues or anything else, it would probably stop you from getting promotion. Promotion was tough enough as it was. So what people used to do, if they had any underlying conditions, they wouldn't let people know, because what they thought underlying conditions would mean that they wouldn't get promotion. And what I'm saying to people today is that has got to change. They really do need to let people know if they've got underlying conditions, because they cannot go onto the front line unprotected, and people can't protect them if they don't know what's going on with them. And remember, we look very healthy and we look really well for our age, but looks are very, very deceptive because we've got the underlying inequality issues going on here. And I'll stop there. Thanks.
Yeah. Can I just ask as well, on the back of this question then, because it's also been written as well this past week that NHS trusts should be risk assessing all of their BAME staff in light of the information that we've gleaned. So potentially, and shield, and the BAME staff should be shielded in terms of the 12-week shielded, as if we've got, you know, an underlying long-term condition. So what is your opinion on that? And if it was to occur where, you know, all BAME staff were shielded for 12 weeks, what is the impact of that in the NHS, considering, I haven't got the figure right at the forefront of my head, the percentage of BAME staff working in the NHS right now?
Yeah, so it's really important, Bev, to be clear that the guidance doesn't say that these staff should be shielded just because they come from an ethnic minority community. Okay. That's not what it says. That might be what the kind of myth version is. What it says is that managers should have an explicit conversation with ethnic minority staff to say, look, exactly as Councillor Hamilton said, you know, lots of staff feel scared to disclose if they've got a health condition. It gets in the way of promotion, you know, and that what they're saying is managers need to have an explicit conversation that says, look, we need to know if you've got high blood pressure and you haven't been telling us because you're scared, you know, we need to know, because we're not able to do right by you if we don't know what's going on. The second part of the NHS approach is to have a conversation that's about how's the stress of all of this affecting you. You know, if you come from an ethnic minority community and every morning for the last week you've switched on the TV or opened a newspaper and it says ethnic minority people die from this more than anyone else, it's scary and it's stressful. So the second part is about acknowledging that and having a conversation about what support is available. You know, in Birmingham, we have a special helpline set up with the Mental Health Trust for health and social care staff and other essential workers, where people can ring and have a confidential chat about how they're feeling. You know, and that's there are different variations about that across the country. So you know, the important bit is it's not about shielding everyone. That would cripple the NHS, and it would certainly cripple social care.
Certainly.
But if the evidence said that that's what we needed to do, I'm pretty confident we'd do it. That's not what the evidence says at the moment. The evidence says, actually, these communities have more health conditions and might be more at risk. So you need to have a proper, explicit conversation with them. And we should be doing it for all our staff, actually, because we don't know what's going on with disabled people at the moment. We don't know what's going on with lesbian and gay, bisexual or trans people. We don't know what's going on with different faith communities because the NHS doesn't collect that data and hasn't done the analysis yet. And there are serious concerns that it's, you know, many of the issues that are raised, and I know the next question is coming, but many of the issues that are raised about people feeling that they can't complain, they can't raise their heads above the parapet because they get chopped off in the way Councillor Hamilton said, that's not just about being Black or being Asian. It's many people from minorities experience that. We just happen to have the data first for ethnicity. I've got a strong suspicion that once we get the data for learning difficulties or for autism, we'll start to see some scary patterns there as well.
Yes, indeed, indeed. Some general thoughts from one individual. I don't know what your thoughts and comments are regarding these statements. I'll read them quickly. Come down, Brother Mark, come down. I need to see number 1, please. Thank you. That's fine, thank you. The Black community are not offered the same medical resources as other communities. We are viewed as exaggerating our symptoms. This is one individual. We work twice, if not 3 times as harder as our professional colleagues. Those from less fortunate backgrounds must work 2 to 3 jobs to make basic financial decisions. Even though we hold professional jobs, we are still not paid equal to our white colleagues, both male and female. Most medicines, they're not tested on the BAME community, therefore the effects are different when we are prescribed them. Above all, we do not question when our superior give us a task, request to carry out as part of our duties, even though we know it's not right, therefore putting ourselves at risk. What are your thoughts on those comments? Do they ring true?
Are you talking to me, Bev?
Oh, well, yes, Paulette. Let's go with you, Paulette.
Well, I'll tell you how I feel, and then Justin will tell you the facts. I was in the health service, and that's how I felt. So I cannot say that the perceptions are not out there. What I do think needs to happen, there needs to be far more education. People need to build up a level of trust, and people need to understand that people's perceptions are real. And at the moment in the health service, sometimes that is not accounted for. So even though deep down, now I'm not in the health service, I actually know it's not true, a lot of this. And also, I'm going to preempt what Justin will say about other groups feeling the same way. But to be honest, there needs to be a lot more work with people of color to build their trust, because that has absolutely, for whatever reason, it has broken down. And I'm going to stop there because I think Justin should give the real facts. Justin?
Oh, sorry. Yeah, I mean, I think I agree with Councillor Hamilton, and you know, that I absolutely recognise the perception. I think these experiences are not unique to the Black community and not really unique to ethnic communities. People who are lesbian and gay, people who are disabled, experience these as well every day. Particularly that sense of you can't raise your head above the parapet pit because you will be shot down sooner. And how dangerous it feels if you're in that situation to raise those concerns. I think in terms of whether it makes us more susceptible or not, I'm not sure it changes the way the virus attacks our body, although I would say that actually living in this state, any of us who come from minority communities experience a kind of daily chronic stress of discrimination. And of that feeling, and whether that's because you're Black, or whether it's because you're gay, or whether it's because you've got a hidden disability or a visible disability, that wears you down, and that will have an impact on your health resilience, how strong your health system is. And we know that from some of the other research. So that means when there is something like this going around, you probably are, your kind of response is less good than people who aren't experiencing that chronic discrimination, some of it direct, some of it indirect. So I doubt it's something necessarily that the research will show, but I do recognize the experience. And I also think that, you know, the reality is this bears down on us every day in different minorities in different ways, but every day. And that stresses our mental health, but also our physical health. So when we get sick, it hurts more.
Okay. In terms of the African Caribbean community and the disproportionate numbers that are affected by COVID in the UK, the next question is the disproportionate numbers of COVID in the BAME community has been attributed to long-term conditions like diabetes, multi-generational households, And that term itself, that's being used across the board from some of our understanding. But multi-generational households is not across the board in BAME. Just wanted to say that, and possible other factors. But in the Caribbean and in Africa, the death rates are far fewer. So what's your view on that?
Yeah, it's interesting. I was just having a conversation with a friend of mine who works in the World Health Organization specifically on that point today. And realistically, we don't have a good sight of what's going on in Africa. It's a bit better in the Caribbean, but actually there's very little understanding, partially because in areas like South Africa, who've been doing really good track and trace, it's all been based on clinical history. So that's not necessarily coming through in their death data, because they're not doing laboratory tests, and different countries have got very different approaches to capturing death data. So one of the issues at the moment with the international comparison is you're really not looking at apples and apples. You're looking at not just a fruit bowl, it's a fruit and veg bowl, in terms of the way that different countries record this. So I think it's quite hard to actually really understand what's going on in both Africa and the Caribbean. The other thing is that we do know that people's health here and people's health in their country of heritage is quite different. So in general, African and Caribbean people in this country are much fatter than they are if they'd have stayed in Africa or in the Caribbean. And that's because here they adopt a white British diet or a kind of hybrid diet, and they're not as physically active. So all of those things come together. So it's not straightforward in terms of the data, but also actually we know that people who migrate to different countries don't have the same health behaviours as if they'd have stayed in the country of origin, if that makes sense.
Could I throw in a scenario here? And I'm definitely throwing in a scenario. Africa and the Caribbean, as soon as this disease hit their shores, they shut down the country. Because of their past experiences with things like Ebola, they haven't got the health system to actually deal with the kind of outbreak we've had in the UK. So what they've done, they put measures in place very quickly. And what a number of those countries did, they did the testing, they did the tracing, and they made sure that at the beginning they started that piece of work where we procrastinated in the UK for probably a good 3 to 4 weeks. And I believe this is why they have had a better outcome than us, because I believe they've planned things because of what has happened to them in the past. And it has worked out at the moment better for a number of those countries you talked about. And that, I'm just throwing that in there.
Yeah, and that's a valid point. And what has happened in terms of perceived late testing, flights that were still coming in from outside of the UK, and people coming off those flights weren't tested like other countries that were having their temperatures taken. That has happened, and that could have contributed to the increase in deaths. But also in terms of Africa and Caribbean, do you think that there's any implication around vitamin D at all? Because obviously in a hot country,
yeah, it's an interesting one. Yeah, it's interesting. So vitamin D is one of those ones where the evidence base in terms of COVID is a bit patchy. So there are some papers that say there's correlation with having low vitamin D, and others that say there's no correlation. And there also isn't a particular pattern. So we are seeing large numbers of cases in countries like South Africa, for example, where there is some of the better testing. And we have areas of the world like the Middle East, where Bahrain particularly was hit incredibly hard by coronavirus and had a very high rate of death. So we don't think it's a climate relationship thing or relationship with how much sun. That being said, Public Health England did say, I think about 10 days ago, released an additional bit of guidance saying all of us should be taking vitamin D supplements at the moment because we're inside more. And those simple over-the-counter vitamin D supplements are unlikely to do any harm. So my advice would be take them. I certainly normally, in normal times, take a vitamin D supplement because I'm often stuck in the council house for long hours outside of the sun. So, you know, I would say, you know, this is one where we can all do something. If it makes it a benefit, even if it's small, probably worth doing. But you don't need anything particularly special. Over-the-counter vitamin D is perfectly fine. And make sure you read the kind of label if there are any exclusions. Vitamin D is one of those things that's quite hard to get from your diet. And it's the other reason why we should be getting out of the house and doing that physical activity every day. You know, an hour out in the sun will help. But if you've got black skin or darker colored skin, you may well need to take the supplement as well.
Okay, thank you for that. Could you scroll down for me, Mark, because I think the question in green has been answered. And I believe that my next questions have also been covered as well. So shall we go to Sister Lorna? Sister Lorna Campbell?
Good evening, everyone. Question, good evening. The question being asked by Errol Waldo. Should BAME groups with underlying health issues such as diabetes, blood pressure, heart disease be shielded?
Yeah, so I think one of the things to say is, you know, the kind of what's the added value of shielding? So if you've got high blood pressure or diabetes or heart disease, you're already on the vulnerable list. So if your employer knows about it, you should be having a specific risk assessment about what your role involves. And whether you need to be, whether you're able to work from home or what adaptation needs to be made for you. The only real difference to the shielded list is those people got a letter that told them they need to stay inside for 12 weeks. And they get a food package if they need it of very, very basic food items. This is not a gourmet delivery from the national distribution. So I think that the question is, you know, what's the value of being on the shielded list? But they are already actually on the high risk list if they've got any of those conditions, and should be being a bit more careful than people that haven't. That's no different from people who are over the age of 70 or pregnant women. So I think, you know, the list is already there, whether it's been heard as clearly as it might. And I'm sure when we get out of this and the great wash-ups and the inquiries, one of the points that probably will be made is that, you know, was there more we could have done to help people really understand what being on the high risk list means? Because there was a lot of media coverage of the shielded, but not so much on that other group.
Can I make a point there, Lorna?
Yes, go ahead.
Right. Justin always gives the facts as they are now, and I'm just going to say what I believe will happen in the long run, and I deep down believe should have happened. People that had high blood pressure and people with uncontrolled diabetes and high blood pressure, I believe they should have been assessed and taken off the front line because they were at much higher risk. Not about the color, not about the race, not about the nothing. It's about people with high blood pressure and that wasn't controlled, and people with diabetes, and if they were overweight and it was not controlled, I believe they should have been taken from the front line. They should have been assessed, they should have been risk assessed, and if it was really quite bad, some of them I think should have been offered shielding. This is what I think will come out in the long term because of that issue around people getting COVID-19 with high blood pressure, diabetes, with and being overweight, and if they're men, what the outcomes have been. That is what I believe. Thank you.
Going on from the word shielding, I think I'll just jump down to this question about, Dr. Varney, could you explain the difference between shielding and self-isolating, and how you would be treated differently when speaking to your GP or presenting yourself at A&E?
Sure. So in terms of shielding, or if you're on the high risk list, so the vulnerable list, if I deal with that first and then I'll deal with self-isolation. So shielding, those are the people who've had an organ transplant or are on drugs which stop their immune system working properly. They're the people that should really not leave the house unless it's absolutely essential, and shouldn't have any, shouldn't be mixing at all. None of us should be mixing, but for them it's super important. And that's because we know that coronavirus in them is much more likely to be fatal, I'm afraid. Now, if someone is shielding and they need to go into hospital, for example, or the GP needs to come and see them, or a carer needs to come and see them, for example, then if the NHS or the social care service know, then they will be using more protective equipment to protect the individual, and they'll be super vigilant around making sure that they don't bring anything into that person's house. Now, the vulnerable group, which is those over 70s, pregnant people, people who would get the flu jab, are not as so tightly protected. So they can go out and do their shopping, they can go out and do their physical activity, but they've got to be more conscious. They really need to keep those 2 meters of distance and kind of try and protect themselves as much as possible. Now, those things are different from self-isolating. So self-isolating is the term we use when we say to someone, you've got symptoms and you need to self-isolate, and that should be for 7 days until those symptoms have got better. And that's because you're most infectious with coronavirus for about the first 4 to 5 days of having symptoms. Your household also need to self-isolate for 14 days. And if you're self-isolating, that means not going out at all. And really staying at home, no exercise, staying at home, and only going out if it's absolutely essential. So self-isolation is about protecting the world from you if you develop symptoms. Shielding and the vulnerable staying at home is about protecting them from the world. Does that help kind of make sense of it a bit, Lorna?
I hope so. I hope that helps clear up for the listeners as well. Another question here that we've got is someone saying they've got heavy breathing. Is it still okay to go to work even though they don't feel sick or have a cough?
Yeah, it was interesting when I read this, and I was discussing a little bit with Councillor Hamilton some of the questions you shared with us before. And one of the questions that came up in the chat about, do different ethnic groups have different presentations of COVID? So in general, we don't think that there are specific differences between different ethnic groups in terms of how COVID presents. However, different cultures describe symptoms in different ways. So when I did my medical training in East London, I worked with a lot of Bangladeshi elderly women. They would talk about all over body pain. And that was their presenting symptom, and that's how they described what they were feeling. Now, that could be that they had an appendicitis, or it could be that they had extreme fatigue because they were anemic. And you had to understand that to be able to kind of tease out what was being meant. So when I read this question, I was a bit like, what does heavy breathing mean? What I would say is that if you have a new symptom, so your breathing changes for what's normal for you, and it's lasting more than a minute or two, more than a couple of minutes, then you need to talk to your GP. It's not about whether you go into work, it's about actually, if you've got something that changes in your body, you should be talking to a healthcare professional. All the GPs are set up to do telephone consultations, video consultations, and then they've got special sites where they can see you if they need to examine you physically, both for people they think have got COVID and people who haven't, to try and keep them separate. But if you develop a new symptom, you need to talk to a health professional and not sit at home in silence.
Thank you. And this one, where the person states that they've been shielding, they've not left the house, but yet they've got the disease. And it's one of those questions that a lot of people have been asking. Someone hasn't left the house, but they've still got the symptoms.
Yeah, I mean, it's a difficult one because, one of the challenges with this is that, there's very, very few people who've actually not left the house at all. And it only takes kind of one bit and not washing your hands and touching your face that transfers it. The other issue is that we know that the virus does live on things, particularly hard surfaces. So if you're shielding, and a couple of weeks ago, back at the start, I took a lot of questions from this when I was doing some of the radio interviews about what should people do with their shopping. So, for example, if you are shielding, you need to be that little bit extra careful because the virus could live on a can or it could live on a parcel. So you need to wash your hands after you've handled anything like that before you touch your face, because that's the risk. What happens is you touch something that's covered with the germs and you forget to wash your hands, and then you just scratch your face or you wipe your forehead, and bam, the virus is on your forehead and it crawls down into your eyes. So it's really that good hand hygiene. You can't, as far as we know, it doesn't infect you through food. So the food itself isn't the infection, it's the touching of it. So if you've got food that's in tins or in packages, washing them down, giving them a wipe down. If you can, leave them in a room for a couple of days. If there's something like a tin of beans, just put them to one side in the cupboard for about 3 days is the maximum we think the virus lives for, and avoid touching them. But it really, that's one of the ways it might be getting in, because I think, the more we learn about this virus, the more we learn it is quite a resilient little thing. And obviously cooking food kills the virus as well. But in your food prep, you should be washing your hands anyway, and that's what stops it getting into your body.
Yes. And I think finally, from my questioning, if someone works in a care home and they're vulnerable and they live in a small space, how can they protect themselves?
Yeah, so there is information on the national website about this and about how to stay safe at home. And I think if you are someone who works in where your job still means you have to go outside, then what you should do is wash your hands as the first thing you do when you come inside. I know many of the people that I know who work in healthcare have a set of work clothes, and what they do is they come inside and the first thing they do before they kiss their other half or do anything else is go straight into the bathroom, take those clothes off, put them in a bag that's then sealed, it's just tied and closed, and have a shower and put on some different clothes. And that's one of the ways of just making sure that, although we don't think it spreads particularly on clothes, that you just reduce that risk a little bit more. But the most important thing you can do is the first thing you do when you walk in through the door is wash your hands, because actually that's the thing that we touch things all the time, and that's how we carry the germ about. So it's wash your hands. And if you are working in something like a health or social care setting, then I'd wash my clothes. Some care homes, for example, are setting up, and some hospitals, GP practices, where people are going in and they're getting changed at work, and their work clothes are staying at work, and work are washing them for you. So that's kind of one of the opportunities as well. I'm conscious someone also just asked a question about, just picking up on the food thing in the chat, about takeaways. Takeaways have had really clear instructions about how to make sure your takeaway is prepared safely. Delivery, Just Eat, all of them have worked out how to drop it off in front of your door, step back and let you pick it up without coming within the 2 meters. And again, when you're handling the boxes, the containers, wash your hands before you touch your face, because that's the risk. And the worst thing you can kind of do is handle the box and then go grab a slice of pizza, put it up to your face, and then while you're there, touch your face and put the germ on your face.
Thank you very much. I'll hand back to Beverly. Thank you.
Thank you, Lorna, for your section. We're actually going to hand over to Pastor Donna. Pastor Donna?
Okay, good evening, everyone. Good evening, and thank you for being with us this evening, and I feel it's going quite well. Thank you to everybody that's watching also on YouTube, and we are really grateful that you're joining us in that medium. So my first question is not one that you've received, but one of the chats is, it has been said that some people go into hospital and straight onto a COVID ward, even though they do not feel they have COVID. What is the explanation for this?
So I'll start on this, and if I ask Councillor Hamilton to come in, because I know that she's been super active whenever we've come across something like this being reported, and it's actually through her intervention at the start. But that's one of the reasons we did the special board and got the NHS really moving on this. So I think what we've learned is that there are some situations where people have presented to A&E and they presented with symptoms that could be COVID, but they're not the ones that we see in the media. So particularly in elderly people, chest infections often present as confusion, acute confusion that's called delirium. And if you do all the other tests in A&E that you would normally do for someone with delirium, and you ruled out a water infection, which is usually the most common cause of acute confusion in an elderly person with a temperature, then it is reasonable to go, this is probably COVID or a chest infection that's COVID-like. And it's important to understand that COVID, when someone comes into hospital, the diagnosis of COVID is based on their clinical history and their clinical presentation. It's not about whether you've had the lab test or not, because the lab test can take up to 2 days to come back. And what we need to do as healthcare professionals is they need to look at you, diagnose you, and treat you the best possible way based on what you've got. So we know that in some cases that was what seemed to be happening, but it wasn't explained. And therefore people felt very angry and upset and confused about what was going on, but there wasn't, the NHS sometimes hasn't always been best explaining what's going on and the rationale about the decisions being made. But ultimately, people coming into hospital, the COVID diagnosis, unless they had a swab in the community, is based on the clinical history and the presentation rather than a blood test or a swab test. But I know, Councillor Hamilton, you were very involved in some of these. Do you want to explain?
I'll just say, because you said most of it, to be honest, I'll just say, relating to people that go into hospital, I think as family of those that go into hospital, you need to question, and question again until you get the full understanding. Because as Justin has said, 9 times out of 10, your loved one is going into hospital, they're told you're being put on a COVID ward, and it is not explained why that is happening. Also, a case that I came across, the young lady was told that a relative, even when if dad had the test, he would stay on the COVID ward. It was the wrong information. So the point I'm saying to you is, you have got to keep challenging the health professionals till you're happy with what they are telling you, because this is a disease that kills, but fear is not going to help us overcome it. It's education, it's understanding what the issues are, and it's challenging the health professionals till you feel that what they're saying, you absolutely understand. I have to be honest with you, whenever I've gone in and challenged, they have been more than happy to tell me or the family concerned, the absolute story or the absolute truth. But 9 times out of 10, families are told dad or mom or sister are going onto a COVID ward. They panic, but they don't actually say what their concerns are. Thank you.
Thank you, Councillor Hamilton, for that. I think Dr. Varney has answered a question on the chat regarding black parents and should they be sending their children back to school when school reopens, and they're instructed to do so. And an additional question to that is, what if the parents are at high risk?
Yeah, so I'll just read it out or give a response verbally as well for those that can't see the chat. So when we do get to the point when schools reopen, which I don't think will be for quite a while, I still think we've got a long way to go before we get major relaxation of lockdown, to be honest. It'll be very small steps, very slowly. Is that the Department for Education will provide very clear guidelines about which children should be coming back to school and which shouldn't, and there is some more understanding about what children are affected by coronavirus. Still, very small number catch it and get sick from it, and the evidence suggests that they're not very good at spreading it, particularly small children in primary and nursery school. Now, this might be because the primary and nursery schools are very good at getting them to do the hand washing, so they don't bring it home, whereas secondary school kids are not quite as compliant. For those of you that have teenagers, know the challenge of getting them to do anything. So, if this had been a virus that children were very good at spreading, in those first couple of weeks during the kind of end of February, when kids were coming back from the high-risk region of Italy, we would have seen major spread attached to schools. And we didn't, even when we had schools where we had confirmed cases of children and parents, it didn't spread particularly in those schools, despite a lot of testing and a lot of looking to check for it. So I think we're reasonably comfortable that actually children aren't a particular risk for bringing it back from school. And if they go to school, school isn't an incubator. It doesn't seem to be a space where the virus spreads. And that's really down to all the hard work the teachers are doing to make sure the kids are absolutely on top of the hand washing.
Thank you. Thank you. I want to move on because I'm conscious of the time. In view of the high prevalence of BAME in Birmingham, the largest council in the UK, will Birmingham City Council and NHS England be lobbying central government for an increase in resources to employ more health and social care staff, and also provide resources to remunerate people from the voluntary sector to work alongside government and healthcare as a bridge to the community?
Well, I'll start with that one. As the Health and Social Care Cabinet member, the lead, can I assure you that we are constantly lobbying government for more funding? We have gone through 10 years of austerity, and during those years, every single year, my budget has been cut. Every single year. What they've done sometimes, they've given us grants to help us meet the shortfalls or in different areas, but it has been terrible the way that adult social care has been funded. And we have been lobbying for adult social care to be funded in a different way. We have been lobbying to get more sustainable funding. We have been lobbying for more resources and for adult social care not to be treated as the second cousin once removed. Because in health, if they don't meet their control targets, sometimes the government will wipe it out. In social care, if you don't meet your control, your budgets, you get into a lot of trouble with government. So can I assure you, there is a great deal of work going on out there to ensure that councils are funded in such a way that we can actually increase the resources. And I won't go into it, but there is something called that we are trying to do far more integration with health so that we get more parity, because at the moment, if you are a care worker, your promotion, the way you get promoted, the way you go through the system is far poorer than if you're in health. And if you work within care homes and what have you, it's just seen as a dead end. So what we need to do is ensure that we get a proper career progression, both in health and social care, so people can see it as a career of choice, and we can get really good people coming into that service to deliver the care, the management that we need throughout. Thanks.
Thank you.
Could I just add to that? And you know, what we've also seen is big cuts to the public health funding. In Birmingham, I think we're over about £10 million in the last 5 years taken out of public health, and the public health system as well has been significantly shrunk, not just locally but nationally. And some of the challenges we've got now responding to this outbreak actually is because that system is significantly smaller than when I first came into it back in 2006.
Great,
But
thank you.
can I just say, with public health, again, it's the system that I'm over. The problem has been with public health, it has had a grant that has been ring-fenced and the government has just slashed it. And they have not given us the opportunity to try and even bid in to increase public health. And I think with this going on, with COVID-19, it's an ideal opportunity. If we are going to look at health inequalities, to absolutely be lobbying government to say that public health need the resources to do that work around the larger piece around health inequalities.
Okay, thank you, thank you. I've got a number of questions, but I'm going to ask just one more question, and I know that you have the questions and would be able to respond to us outside of this meeting. What local help can be provided to BAME communities now? What engagement is there with faith and community groups, schools, helplines for BAME communities? And what and where are the resources to help BAME communities? Who are our local responders?
Justin, do you want to go first?
Sure, I can do.
You have absolutely broken the internet with everything you've been doing. But anyway,
sure.
Go on.
So in terms of kind of the engagement work we've been doing since this began, so some of you might remember me, you probably first became aware of me, although I came to the city back in February 2019. You probably really didn't see my face until kind of early January and the beginning of February, when I was doing interviews on local radio like New Star Radio and with Birmingham Live to raise awareness across Birmingham. And we've made this very specific and conscious decision to do that with some of our community radio stations like New Style, like Unity FM, to try and make sure that messages were getting out, and it wasn't just the West Midlands BBC. Although I'm really grateful, you know, I've had a regular slot with them on a Tuesday morning, taking questions and answers from the community as well. Alongside that, we've been having meetings with different groups of faith leaders. So every week I've been meeting with the mosques. I've also been meeting with many of the African and Caribbean church leaders, normally on a Tuesday. And then now on a Wednesday, I have an interfaith group, which is open for other faith leaders as well. So we've been doing quite a lot of engagement in that sense throughout this. And I know Councillor Hamilton's been on and off the radio as well, probably more than I have actually, talking about these issues and particularly trying to talk about them with media outlets that we know reach those communities. We've also commissioned some community organisations. We did that through competitive tender to focus on specific minority groups in the city. And we've awarded those contracts this week. We'll be announcing them next week, and they're working with us, with my public health team, over the next 3 to 6 months, not just to kind of work on the immediate problems of COVID, but actually also what's going to come afterwards. Because we know there's a lot of stuff that's building up at the moment in terms of mental health and anxiety, as well as the physical health effects of all that snacking we're doing and sitting on the sofa that we need to undo. So we've put some commissions out there specifically in those spaces. There's been a huge amount of work done with Birmingham Council of Voluntary Sector Services. There have been small grant schemes that are coming out, both from the council but also nationally, that BCVS has been making sure people are aware of. There have been groups going in and bidding for those as well to get money in. So I think there's been a lot of stuff where there's been opportunities. I think one of the challenges has been, there are many different organisations in Birmingham, hundreds at least, if not thousands of voluntary and community organisations, lots of them very small. And actually one of the real challenges, and that's where BCVS has been so helpful, is getting everyone to talk to each other. The real legacy in a positive sense that will come from COVID is that we've got organisations working across traditional boundaries, and actually building bridges and partnerships to find ways forward together. A good example of this is the food banks of the city. Before this, most of our food banks didn't really talk to each other that much. And through this, we've been working with the Active Wellbeing Society to bring all of them together. There's food being moved around the city to make sure that all the banks have got enough. The councils put cash in to put food into the food bank system to make sure that people aren't starving, that food is getting to our poorest communities. So there's a lot of stuff that's been going on. I would say we probably haven't had enough time to share it all, and again, with the joy of hindsight, we probably would have made more of a noise about what we were doing behind the scenes. But I think compared to many other areas, we've learned and we've reflected that we've probably done more than many other cities to actually actively engage. And at the meeting that Councillor Hamilton and I joined on the National Review, I've now volunteered to take the lead for the Directors of Public Health across England to coordinate the sharing of good practice for working with minority communities, because there's lots of little gemstones, and also it gives Birmingham the first chance from learning from anyone else. So if there are gems out there we haven't thought of, I'll get them first and we'll be able to put them into action here. There's still a lot more to do, but actually I think that we have done a huge amount to try and get the messages out and to try and also get people cited on when there's resource there to help support them as well.
And could I just quickly add, before COVID, we were doing an awful lot. And I'm going to give you two examples. The first example is the work that was started with Lewisham around the African and Caribbean, the health inequalities, but looking at the bigger issues. That was launched this week. The work has been going on for a while now, and this week we've finally been able to launch that work, and hopefully some of those findings will be put into the national whatever the inquiry or the review looks like. But this is work that Birmingham has started probably 6 months, 7 months ago, and it goes on. But Justin did something, I always call it, Justin, the childhood trailblazer. Is that what you call it? Yeah. Now that piece of work for me was awesome, because it was a work that it was something that he brought in many community groups. This is long before COVID in the city. And a final one that I wanted to raise was this food conversation that we've got going, because in Birmingham we realized that the city was a city of many minority groups that had many different eating habits. We knew that their eating habits had an impact on their health, and we started the conversation. We've also been out there, we're really good in Birmingham looking at issues around looking at just people's health and smoking cessation. We've done an awful lot with communities, but can I just end by saying Birmingham is a massive city. It's the largest city, I think, in Western Europe. We have nearly 1.2 million people, and it is a city of many different cultures. And sometimes, because people don't see us, they think we're not doing anything. But trust me, these grey hairs didn't just appear. The hard work has gone in. So I just want you to know that we haven't ignored communities. We've tried to work in different ways to ensure that we've engaged as many different parts of the community as possible. And I'll stop there.
Thank you both. And I can actually confirm that I joined the meetings on a Tuesday and a Wednesday, and I really appreciate how hard you are working to connect with faith communities and the general community in order to inform and keep us updated. So thank you both. I will now hand over to Bev, who's going to do a summing up, giving her closing remarks.
Thank you. Thank you. Thank you, Dr. Varney, Councillor Hamilton. Thank you again. At the beginning, we said thank you for, releasing some of your time to come and join us this evening and to be, open and honest with the listeners that have logged in tonight. We really do appreciate your time and really do appreciate you for doing that, because, we recognise that you must have an incredible busy schedule. So thank you for doing that. And Dr. Varney, your multitasking skills are excellent, because throughout the seminar, you have been paying attention to the questions that are coming, face to face, so to speak, and also paying attention to the questions on the chat, live on the chat, and you've been answering those questions on the chat. So fantastic. Thank you for doing that. And you've personalised those questions as well to the person who's actually posed those questions. So it does show that you are interested and you are engaged and you're respecting those questions. So we really thank you for that as well. We've heard so much tonight, and I'm sure we could have gone on for another hour and people wouldn't have minded. But, we are all busy people in different ways. So we have got to draw this to a close. But we've talked about, improving the collation of data where BAME communities are concerned. And I guess that's across the board in terms of this particular pandemic. We've talked about clarity between shielding and isolation. There was a lot of questions where individuals are worried about being on the front line at work, feeling confident to speak up, feeling confident to approach their line managers. And, if you're on the front line, if you have an underlying health condition, you need to talk to your line manager and you need to ask for that risk assessment if it has not been done already. Please go and do that. We've talked about how you're engaging with the communities, different communities, and with the faith communities. And as I said in the beginning, we would love, through Ash Foundation, through the Church of God of Prophecy, however we can actually engage and collaborate and network with the council as well going forward. It has been really, really good tonight. And if the viewers or people that have logged in would like round 2, then I will be coming to knock on your doors and, trying to schedule something going forward. Would appreciate that you are busy and you're stretched. Can I just ask you, Dr. Varney, you mentioned, was it BCVS? Okay, for those that don't understand, BCVS, could you just...
So Birmingham Council of Voluntary Sector, and that's our kind of umbrella voluntary sector organisation. Just put in BCVS into search, or Brum Together, which is the campaign that all the voluntary sector organisations are using to highlight the work that people are doing across the city to support local communities.
Fantastic, thank you. Thank you so much. Thank you. 2 words, thank you. Going forward in terms of these Friday focus seminars, over the next 4 weeks, we will be hearing from specialist staff from Birmingham Community Healthcare NHS Foundation Trust. So we know that there are there's a correlation with COVID-19 and certain long-term conditions that are more prevalent in the BAME community, such as we've mentioned them today, the diabetes, chronic kidney disease, hypertension. So we've got specialist staff that are coming from those services to come and share with us some self-help tips. Dr. Varney said earlier that many individuals with those conditions pre-COVID may not have had the best control that they could have had. Obviously, we can't speak for individual cases, but we want to impart some self-help information for BAME communities. And we're also going to have a session as well with the clinical psychologist as well from BCHC. So next week, we will be engaging with the specialist nurses from the respiratory service from Birmingham Community Healthcare NHS Foundation Trust. So it's the same time, 7:15, and we will circulate as widely as we can so we can get as many people engaged in that seminar. So thank you, thank you, thank you. And I'm going to hand over to Pastor Donna Gordon-Rowe, who's going to close us out in prayer. And if there's any other thank yous that need to be said, Pastor Donna will do that now. Thank you, Pastor Donna.
Thank you, Bev. I do want to give some thanks. I want to thank you, Bev, and the ASH team for again putting on a great session this evening. We would like to thank Mark and Steve. Wouldn't do it without you, and you've just been so special in getting us on and doing what we needed to do. Obviously, our guest speakers were really pleased, and I am reading the comments, and they are all very, very positive comments from this evening's session. I'd like to welcome Pastor Laurel and Pastor Paulette. It's good to see you both, and thank you for joining us. And also those of you outside of Birmingham that have joined us, thank you very much. So I'm going to close in prayer now. After I've closed in prayer, the Zoom will remain open for about 10 minutes, just for a bit of networking and fellowship, and then we'll be closing it down. But thank you to everyone who has joined us this evening. We really appreciate your input. Thank you for your questions. If there are any further questions that you have, please let us have them, because we can pass them on to Dr. Varney and Councillor Hamilton. So God bless you as I pray. Father, we bless you tonight and we give you praise. We are so thankful to you that you have joined us together in this media just to look at the impact that COVID-19 is having on BAME communities in particularly, but also what we can do to support each other. We really thank you for our speakers, Dr. Varney and Councillor Hamilton, and we pray a blessing over them and a covering over them, Lord, that as they continue to pursue this work, Lord, it's not that easy for them and they are engaged in so many different ways, but we ask you, Lord, that you will be with them. And for everyone that's joined us today, I pray, Lord, that the information that we've heard today has been beneficial to us, and we too will look at ways in which we can support each other. Remember the ASH Foundation team. I pray, God, that you'll continue to strengthen us, that as we put these initiatives on, Lord, you will continue to give us that creative energy, the motivation, and the willingness to do your will. We give you thanks as we go. In Jesus' name, amen.